If you like this story, make sure you listen to Zebras and Horses, because they go together. The milk aneurysm. The call, Tuesday night, 9:22 p.m., 31 Delta, unknown fainting, 65-year-old male, corner of Charleston and Main Street, in front of the 7-Eleven. I was an intermediate with some random paramedic that signed up for my truck. We were downtown because he was on my truck, duh. Most medics don't want to work downtown, and when they see me, they know exactly where they are going to spend their shift. Yes, it says paramedic on the side of the ambulance, but not so much on this truck. Fire was on scene before us. The patient, heart rate 118, blood pressure 94/44, respiratory rate 36/02/88, blood sugar 94, temp 98, was supine, face up, in the driveway of a 7-Eleven. The rescue was parked in the lot, off to the side, so we parked protecting ourselves and the patient by blocking the driveway with our rig. Stupid fire. We got out, walked around, and found a semi-conscious elderly male patient that was fading fast. There was a gallon of milk on one side of him and a bag with bananas, eggs, and bacon on the other. Fire was trying to ask the patient questions, but my paramedic already had the backboard ready. Buckles unclipped, straps hanging, gurney lowered. He was right, too. Altered patient, unable to tell us if there are additional injuries. Protocol demands we take full C-spine precautions and backboard him. And in just the 3 minutes it took us to do all that and lift him onto the gurney and put the gurney in our rig, he, heart rate 106, blood pressure 72 over palp, respiratory rate 18/02/86, was even worse. Damn. Fire rode in with my medic, and it was code 3 lights and sirens all the way to UMC ER. It was our choice between the ER and trauma. Both were in the same hospital, but the medic had to decide which was appropriate for this patient based on scene data. Take a deep breath and evaluate the situation. The patient was found down, supine, in a busy driveway, but there wasn't any evidence of blood or obvious physical trauma upon closer inspection. His groceries were still next to him and not scattered. All this evidence supports the fact that this wasn't a motor vehicle versus pedestrian accident, and if it isn't trauma, it must be a medical emergency, and that means we're going to the ER. The medic must have made the same determination because he made the tele to UMC ER. Truthfully, as an intermediate, I can pretend the ambulance is mine all shift long. But when there is an emergency, it is all about the paramedics. They ride in the back and I drive. The patient may live or die, but it's my job to bring the medic safely back to station at the end of our shift. We have a saying that goes, there's only room for one ego on this truck, and it says paramedic on the side of the ambulance. As a paramedic, I'll expect the same from my partners. For this patient, though, heart rate 92, blood pressure 60 over palp, respiratory rate 8/02/83, it was a hot return. No stopping to ask surprise taxi cab drivers for directions to the closest hospital, because returning hot is not the same thing as running code 3 to the call. Even though it's an emergency, even though it's life and death, I have to remember that there are people standing and working in the back of the rig. Actually, lights and sirens, code 3, or running hot, is really nothing more than loud noises and bright lights. Lights and sirens are only me notifying you that we are nearby. They are only a request to pass, although most every employee seems to think it's permission to shout the most horribly racist things at you for failing to yield. Lights and sirens do not give us any special status or permissions. We are not a government agency like the fire department. We are a quasi-government agency and can be individually and criminally prosecuted as such. The problem with lights and sirens is the adrenaline rush. It tricks you into thinking you're invincible and that your movie is more important than everyone else's. But it's every driver's responsibility to obey every law and never put themselves, the patient, the medic, or anybody else on the road in harm's way. Driving code 3 on the way to a call is stressful enough, but returning hot is the worst. And my decision from day one was to drive carefully and never, get in a drug test. The patient was dead. Heart rate 0, blood pressure unobtainable, respiratory rate 0 by the time we got to the hospital. The doctors tried to save him, but nobody except Nurse Debbie realized what the true nature of the emergency was. The doctors shocked him, did chest compressions, and started another IV. My medic and fire could only get the one. They shot him, heart rate 0, respiratory rate 0, up with 3 rounds of epinephrine and atropine, trying to restart his heart, but in the end, the guy stayed dead. As a last-ditch effort, the doctors pretended the flatline, a systole, on the monitor was fine V fib and shocked him, heart rate 0, respiratory rate 0, one more time, just to be sure. When a hot return comes into the hospital, the other crews all gather round to watch. The emergency room quiets, and the air charges with silent energy. The opposite is just as true. Immediately upon resolution, good or bad, everybody else walks away. They lose interest, and it's like somebody turns the background noise dial back up. Everybody goes back to whatever they were doing just before. Even the other patients. It's weird to watch. After the show was over, the ambulance cleaned and restocked. I went back in for a quick debriefing from Debbie. She's a big woman in her 50s, had a beak of a nose, and has been a nurse since forever. She was super nice, always hugged me, and I liked watching her work because she made the job look good. She always knew everything because whatever the problem, she had already seen it hundreds of times. I gravitated toward her because she was smart and could break down the problem just right for me to understand the mechanics of it. By understanding the hows and whys, I will have a better grasp of the situation the next time. She must have known that by the way she encouraged me. Debbie said the guy died of either a AAA, an abdominal aortic aneurysm, or a TAA, a thoracic aortic aneurysm. She said it's a fairly common rare call. Usually it's an old guy lifting stuff when he feels a sudden tearing abdominal pain that radiates into his back, and they just lose conscious and die from bleeding out into their belly. She said most everybody thinks it's a heart attack. She said the difference was subtle but obvious. A patient in cardiac arrest collapses and dies right there, face down. Patients with an aortic aneurysm lay themselves down supine, hoping it'll go away. And so, are you asking the question that I asked? If the problem was an aneurysm and he bled out into his belly, why were they giving the guy epinephrine, atropine, and repeatedly shocking him like he was having a heart attack? Debbie tilted her head down so she was looking at me over her little half glasses. She slid them off her nose and dropped them onto her big boobs where the hang chain stopped them just before they fell off. She did all that without ever taking her eyes off mine, and probably a little for dramatic effect too. Now that she had my attention, she asked, "Yes, why did they? If you had taken him to trauma, do you think they would have shocked him?" This was a surgical solution, nothing else. And that's why they shocked him. Because we don't do surgery in the ER. The milk aneurysm.